If I could have your attention, please. My name is Father Gabriel Pavarnik. I am the director for the Center for Catholic and Dominican Studies here at the college. Each year, the Center for Catholic and Dominican Studies sponsors a series of lectures made possible by the generosity of the Quinn family, namely Edward J. Quinn, class of '63, and his wife, Kathleen Riley Quinn. Their initial gift to the center has set into motion a dedicated series of lectures that are given throughout each academic year, spanning the broad range of possible Catholic and Dominican study points. The annual St. Joseph Lecture on History, Peace, and Justice has been formed in honor of St. Joseph, described in the scriptures as the just man, and as we know, the foster father of Jesus. He is also the patron saint of the Universal Church and the patron saint of the Dominican friars of the province of St. Joseph, who founded Providence College. We gather today on March 24th, which is not the feast day of St. Joseph. It's 5 days late, but I didn't think any of you wanted to come back from spring break to have this lecture. And since I was in Greece for spring break, there was no way in hell I was coming back. It's also, though, 1 day after, or 1 year and 1 day, after the passage of the Patient Protection and Affordable Care Act, or what most of us simply call Healthcare Reform Act. It seemed only appropriate in a year in which the center itself has initiated a campus conversation on the common good that we not let this anniversary go by without addressing the timely issue of healthcare and its reform. To that end, it is indeed my pleasure that we have in our midst this day one duly apt scholar to speak on this issue. Dr. Robert B. Hackey is a professor in and the director of the Health Policy and Management program here at PC. He earned his doctorate in political science from Brown University in 1992 with a concentration in public policy. His principal area of research and teaching lies in the area of comparative state health care policy, cellular phone regulation, can you hear me now, and healthcare reform. He is the co-editor of the 2001 publication, The New Politics of State Health Policy, and the author of Rethinking Healthcare Policy, The New Politics of State Regulation. He has published numerous articles, is widely praised here on campus for his work, and in 2008, received the Joseph Arachino Excellence in Teaching Award. It gives me great pleasure to welcome my friend to the podium, Dr. Bob Hackey.
Thanks, everybody. Thank you for the kind introduction. Hope I live up to billing. My goal here today is to give you a sense of where we are a year out. It's a real pleasure to be here this afternoon. I'm honestly really touched to be invited to do this year's St. Joseph Lecture. I'm grateful to Father Gabe and to the Center for Catholic and Dominican Studies for this opportunity. My presentation is pretty low-tech. You may have seen folks wandering around the room with various colored papers. You should have 3 of them. One is a springy green, the other is a springy yellow, and the other, because we ran out of springy colors, is a buff. Okay, so Father Gabe is out handing out goodies as we speak. We're going to come back to those later in the presentation. What I've tried to give you is some information. It's the most recent information we have available of survey data, public opinion data on healthcare reform over the past year, and the most recent survey was actually concluded about 2 weeks ago. So this is about as current as we can get. What I'd like to try to do is to place what happened over the past year in context and give you some sense of how we got here and also where we're going. So I want to focus on 4 principal themes today. And the first one really draws on a new project, well, not for me new, but it's hopefully coming to fruition soon. I'm finishing up a book manuscript, which will hopefully go in the mail next week. And that's anyone who's heard this project knows that's probably not going to happen, but that's the theory, which is exploring the rhetoric of healthcare reform. Namely, how do we talk about healthcare in America? And I've been looking at this taking us back to the early 1970s, late 1960s, trying to get a sense of how we began to talk about the need to reform this healthcare system of ours, and what are the themes of the rhetoric we've had over the past 4 decades. There's a basic message here that I want you guys to take away, and that is that words matter. Language matters. The way we talk about things is not simply puffery. It is actually very significant in terms of what we actually end up with as policy. Words shape policy. I'm going to come back to that. So if we want better outcomes, if we want to have healthcare reform that works, we need to focus on how we talk about both the need for reform and the actual reform itself. So that's my first big theme. Secondly, I want to focus on a concept that really defines much of the way we have talked about healthcare over the past 4 decades, and that's a simple word: crisis. For the past 4 decades, people have talked about the American healthcare system and described it as in a state of crisis. And I want to understand what that means. I want to unpack the meaning of that, because we've used it in a variety of contexts. We talk about a cost crisis. We talk about a crisis of health insurance. We talk about a nursing shortage or nursing crisis. We've talked about a crisis of medical malpractice. The same word used in different contexts, crisis, has shaped how we think about this system of ours. Now, without stealing too much of my thunder from later on, I'm going to suggest that crisis is not, in fact, the right way to think about the American healthcare system. And I think that's important to understand because, again, language matters. So my own work employs a narrative approach to studying public policy. I look at how people talk about issues. I look at speeches. I look at television, both news reports. Some of you may know I teach a course on healthcare and popular culture, where some of the raw material for our class are shows such as Scrubs and Grey's Anatomy and ER. And the interesting thing about that is you see people talking about the healthcare crisis, even if they don't use the words, by how they frame what's wrong with our system. And I want to talk a little bit about that. My third focus, and really the crux of what I want to accomplish here today, is to look at the bill that we passed a year ago. And like everything else in healthcare, it's usually referred to as an acronym. Take your pick, the PPACA, or I think that's PPACA, I'm not sure, or the ACA, the Accountable Care Act. We love acronyms in healthcare. This is a remarkable piece of legislation on a number of fronts. It's probably the most significant piece of social legislation that's happened since the Great Society. So it's remarkable on that level. It's also remarkable because of the reaction to it. You would think for a bill that promises to do what it promises to do, we would have a far more favorable response. And as you will see from the survey data when we talk about that, we don't. The public is honestly, if you want to be an optimist, glass half full kind of person, it's lukewarm. If you want to look more detailed at the data, it's frankly overtly hostile to what we've done. And as a result, many people are wondering about what the future holds for healthcare reform. Now, this whole piece of legislation really reflects this notion of healthcare system as in crisis. And so one of the things I want to do is I want to take us back to 1969, the summer of love. Okay, we got to go back. Neil Armstrong is about to step on the moon, July 1969. And that is an important point for our discussions of the healthcare crisis, because that is the point. If we want to find ground zero here in the discussions of the healthcare crisis in America, that's when we first proclaim the existence of a crisis. Richard Nixon, president at the time, has a nationally televised address to the American people, and Nixon says, and I quote, "We face a massive crisis in this area, and unless action is taken, both administratively and legislatively, to meet this crisis within the next 2 or 3 years, we will have a breakdown in our medical care system which will have consequences affecting millions of people throughout the country." Now, these are pretty strong words. We're predicting a breakdown in the healthcare system. And this sets a tone for the future. Several themes come through again and again and again. First of all, this crisis of ours is a serious one. It's getting worse, and we better do something about it fast, or else things are really going to fall apart. The interesting thing about this from a narrative perspective is that as we look at the way we talk about the healthcare system, After 1969, the things that we used to talk about as problems are now thought of as crises. And there's a difference between problem and crisis. There's an urgency element. When we talk about something as a crisis, it's not usually a ho-hum moment. Oh, we're in crisis. Yeah, what are we going to do about it? No, something needs to happen now. Okay, and the interesting thing about this is that it has woven itself into the fabric of our political culture. If you look around and you look at popular television, news reporting, political campaigns, lamenting the state of the nation's healthcare system has become as commonplace on the campaign trail as pledges to cut taxes or curtail waste in government or spur economic growth. These are the common themes that we see all over the place. As a political issue, the crisis is interesting because it's bipartisan. Democrats and Republicans, while seeming to agree on little else, can find out that they do have common ground. The healthcare crisis is, for them, something that needs to be addressed. Even strange political bedfellows, Richard Nixon and Ted Kennedy, find agreement on the notion that the healthcare system is falling apart and needs to be fixed. So I think the 1970s, the early 70s in particular, are an interesting period because this is the point when Americans kind of think about their healthcare system in a new way. The language and images of crisis frame health policy discussions in the 70s. And the interesting thing is the sense of deja vu you get as you look at political speeches and as you look at various expert reports on this subject over time. You can almost cut and paste language from one period to the next. So from the 70s, you can go to the 90s, and the language we're talking about with Richard Nixon and Gerald Ford is equally comfortable in the world of Bill Clinton. And then you can fast forward to 2009, 2010, and that same language doesn't look out of place in this debate either. And so the crisis notion of the American healthcare system has been one that's really framed the way we think about this issue. And that's true, remarkably, despite big changes in the healthcare system. If you go back to the early 70s, managed care as we know it doesn't exist. And yet, the same language is being used to describe the problems we have in 1973 as in 1993, as in 2009. Now, why is that? Well, there's a number of things going on here. The economist Albert Hirschman wrote a number of interesting pieces on health and healthcare. One of the things that he argues in a book called Shifting Involvements is that with many things in contemporary society, there's a powerful sense of disappointment in what we've gotten. And that disappointment can be seen among patients, providers, and purchasers of care. And let me explain what I mean by that. We spend more on healthcare every year. We spend more than anybody else on healthcare every year. But despite that, many individuals are disappointed with their interactions with the healthcare system. And here's why. Buying healthcare does not mean buying health. In many cases, we spend a lot on healthcare, but we're not any healthier. And particularly the people who are really sick, who are spending a lot on healthcare, are not any healthier. And so for them, the disappointment comes from a failure to achieve what we hope to achieve. And that may be unrealistic, the notion that you can purchase health, but nevertheless, I think that is a source of concern among the public. The other thing I want you to see is that our discussion of healthcare reform has been framed by fear. Fear is a powerful theme throughout our discussions of healthcare reform since the early 70s. Whether it's medical malpractice, whether it's the cost of healthcare, whether it's the uninsured, we are afraid of what might happen. And there's a reason for that, because the healthcare system is important to us. When we're sick, we want to know that healthcare will be there. And in 2006, I think you see this kind of a metaphor. John Kerry, senator from Massachusetts, described the American healthcare system as, I quote, a slow-motion Hurricane Katrina that is ruining lives and bankrupting families all over America. And that's pretty powerful language, and that kind of fear-based rhetoric has some raw emotional power. Individuals worry about losing coverage. Businesses worry about whether they can afford coverage. People worry about whether their doctors are going to move out of state because of higher medical malpractice claims. There's a whole bunch of things that lead us to be afraid, potentially. But this notion that we are afraid and that fear is structuring our discussions of healthcare system reform is really important. Now, I want to step back and address the second question I wanted to put before you guys today, which is, okay, let's look at this language of crisis and understand what it means. I want you to make sure you don't leave today. I'm going to hit this thing. It's just a question of time, so I'm going to adjust here. I have to talk with my hands. It's genetic. I don't want you to leave thinking that I am an apologist for the status quo, that I'm telling you, Pollyanna style, the system is great. Don't worry, be happy. This is not Bobby McFerrin up here. Okay, this is Bob Hackey up here. And I'm not telling you this, that don't worry, be happy. No one is satisfied with the status quo. Providers aren't satisfied. Payers aren't satisfied. Patients aren't satisfied. Yes, I would love alliteration. And so what we need to understand is that I think we've misdiagnosed the problem. And I think the source of the misdiagnosis is that we have a system that has multiple problems, but they're chronic problems. The notion of a crisis suggests an acute problem, like a heart attack. You need to go to the hospital, you need to get to the emergency room now, and you need to get definitive treatment or you're going to die. The healthcare system's problems aren't really like that. They're like a patient with diabetes, high blood pressure, arthritis. They got multiple things wrong. They feel like crap, but nevertheless, it's not one issue. It's multiple issues, and we've got to work on them together over time. Now, I think to go back to the early 1960s, we see an analogous situation. And I think you see it in Dwight Eisenhower's message to the American people, his farewell address. Eisenhower was actually talking about communism, not the healthcare system, but I think the general principle he lays out is equally applicable. Eisenhower says that, quote, unhappily, the dangers we face promise to be of an indefinite duration. To meet them successfully, there is called for not so much the emotional and transitory sacrifice of crisis, but rather those which enable us to carry forward steadily, surely, and without complaint, the burdens of a prolonged and complex struggle. And that's what we face with healthcare reform, a prolonged and complex struggle to improve the quality of healthcare for all Americans. Now, the use of crisis as an organizing principle, therefore, misconstrues the nature of the problem. And it's not that the problems aren't serious. They are. It's not that they're not getting worse. They are. But it's not a crisis. And the reason for that is that we need to build support for long-term management, like you would with a patient with diabetes. Think about checking your blood sugar every day. Think about monitoring a condition over many, many years. That's what we're looking at. The notion of crisis raises the prospect that there's a quick fix, that there's a magic bullet, that we're going to find a solution. And we're not, unfortunately. That doesn't mean we can't have a much better healthcare system than we have today, but we need to work on it over time. And so from this perspective, the proper prescription for healthcare reform really needs to begin with a therapeutic approach to the language we use to talk about healthcare. And this is where I'm indebted to my friend Chris Arroyo and my fellow participants in the 2008 faculty seminar, because we talked about a lot of issues that year. And one of the things that we talked about really stretched my thinking on this subject. I'd never read Wittgenstein before. I met Chris, and Chris managed to get me to read Wittgenstein, which is always an interesting challenge. But it really did shape how I thought about language. And Wittgenstein argues that when it comes to the philosophy of language, we have philosophical difficulties that are produced by what he calls, quote, an unwitting abuse of concepts. And when concepts are abused or misused, or as he says, when language goes on holiday, the resulting confusion stymies philosophical progress. Now, Chris will tell you I'm no philosopher. Okay, I will not pretend to be one here today. That said, I argue that a similar situation is happening in public discourse about the American healthcare system. We have a case of language on holiday. Because what's happening is different groups with different agendas are using the same concept, crisis, but they're using it to describe very different things. And there's no common meaning, agreed upon meaning on what we're talking about. And as a result, we're talking past each other, not to each other in most cases. And so in this circumstance, language is actually an impediment to progress, to public discourse. Because as a concept, if healthcare as a crisis has multiple overlapping, conflicting meanings, then we need to unpack what's going on there. What do we mean when we talk about healthcare as a crisis? And I will argue, and my book argues, that as a concept, the healthcare crisis means so many different things to so many different people that essentially it has ceased to have any meaning at all. The concept, as George Orwell might say, needs to be thrown out. We need just to start over. And I think there are several reasons for this. First of all, aside from the fact that a 40-year crisis is an oxymoron, typically crisis implies a need for immediate action, and 40 years is almost as long as I've been alive, and we haven't done much yet. The issue is that there's no identifiable tipping point. And I don't think there's a better way to see that than the way we talk about healthcare costs. Back in the early 70s, people talked about our share of domestic product, GDP, going to healthcare. And they talked about the notion of 10% of America's gross domestic product going to healthcare as like this catastrophic moment. We can't possibly dedicate $1 out of every $10 to healthcare. The economy will be crippled. It's just going to be too much. Businesses won't be able to sustain it. Government can't sustain it. No one can sustain it. Been there, done that. That was in the rearview mirror a long time ago. By the early 80s, 90s, 12, 13, 14%. We can't possibly spend that much because we can't sustain it. It just won't happen. You're going to run into a wall, effectively. Been there, done that again. We're now spending more than 15% of our GDP on healthcare, and if you listen to most folks, people like Victor Fuchs, who's an economist at Stanford, there is no upper limit. We can really spend a growing share of our income on healthcare. It's a social choice, effectively. We decide to spend money on healthcare as opposed to buying new cell phones or other things that we might want to buy. Healthcare can consume more and more of our gross domestic product. People used to say that we wouldn't tolerate a system where we had 40 million people uninsured. That was the discussion in the late 1980s. 37 million people, moral outrage, we won't stand for it. We're going to do something as soon as it hits a tipping point. Last year, there were over 50 million people uninsured. Where's the tipping point? Where's the point at which we say, it's too much, we can't do it anymore? There is none, obvious. And so these arguments that the system is going to collapse unless we do X, start to lose narrative fidelity, truth value, because it becomes almost a Chicken Little-like exercise. The sky is falling. And we have been saying that in healthcare, the sky is falling since 1969. It's still up there. It's cloudy. It rains a lot. It's unpleasant weather, but the sky's still there. And I think the interesting thing here is that when you look at what the public thinks about reform, and we talk about this rhetoric of crisis, there's a disconnect, there's a disjunction. Because the public has some conflicting views on healthcare reform. I mentioned 50 million people lack insurance. And that's about 16% of the American public. And that's a lot of people. But the interesting thing that comes to play is when you talk to the people who actually do have insurance, most of those folks, the overwhelming percentage of those folks, like their coverage, and they like their health care providers, and they're quite frankly satisfied with the system as it is. And that's a real obstacle to major national health care reform. And I think that's something you have to understand. The flip side of that number, 15% of Americans have no insurance. 85% do. And the 85% who do are largely satisfied customers. And so when you go talking about changing the system to help the 15% who don't, the ripple effects really hit those who do. And most people aren't opposed to giving health care coverage to people who don't have insurance, but they don't want their own coverage to change. Thank you very much. They don't want to lose benefits they have now. They don't want to pay more than they have now. They don't want to have less choice than they have now. They want their cake and they want to eat it too. I'm not saying this is rational. I'm saying that this is public opinion. John Oberlander, who teaches at the University of North Carolina, says, and I tend to agree with him, the status quo doesn't seem like a bad fallback option for people who are comfortably insured. Right now, if you have insurance, if you're like me or any other employee at Providence College who has the college paying 80% of my health care premiums, and believe me, this is not an advertisement for any members of the health care committee that we want to pay more. I'm just saying that right now I feel like I'm in a pretty good spot, as do most other Americans with employer-sponsored insurance where their employer pays a significant portion of their premiums. When you dig down further and you look at public opinion, Americans continue to express a high level of support for the system as a whole. We ask questions about people's experiences with the healthcare system. Every year we have studies on this. 80% of the public rates the medical care they receive as, quote, good or excellent. Now, they like their doctors, they like their hospitals. This high level of satisfaction challenges the notion of a system in crisis or at risk of collapse. And, interestingly enough, and this is a huge problem for us, many people are concerned about costs. Businesses are concerned about costs, government's concerned about costs. Talk to the average American, they're not so much concerned about the overall social cost of healthcare, how much we spend as a country. They're worried about their out-of-pocket costs. That they're worried about. But the notion that we as a society are spending more on healthcare is not a problem. That's often seen as a good thing because it's a mark of progress in a war against disease. So the public has very little appetite for cost containment if it has a bite on my wallet or on my choice. So there's a disconnect here, and this is analogous to something that my friends in the political science department are well acquainted with, which is what we call the Congress problem. In the Congress problem, Americans hate Congress as an institution. It's a terrible place, bad things happen there, but we seem to individually love our Congress people. We re-elect them in great numbers every year. Average members of Congress are routinely racking up high re-election rates. And Morris Fiorina, who first studied this problem back in the 70s, talked about this paradox. We have personal relationships with our Congress people. We like them as individuals. The institution they represent, we don't have so much use for, but they keep telling us every year they're going down there to fight it anyway. And so the healthcare system is similar. We like our own providers, we like our own pharmacists, we like our own hospitals. The system has problems. Now, I want to now look at 2010. I want to go back and look at what happens here. And I think the shortcomings of this approach to thinking about healthcare as a system in crisis are really evident here. Last year, we tried to do something truly ambitious. And it is a remarkable piece of legislation on a number of levels. The legislation passed by Congress is a roadmap for how to expand coverage. And we wanted to do so through a combination of approaches. But the way we've tried to do so is very controversial. And frankly, people don't seem to like it very much. We've tried to do so by a couple of different approaches. On the one hand, we're going to expand Medicaid. For my friends here on health policy folks, Medicaid is the program that provides health care to the poor and disabled. It's a state-federal partnership. We are preserving Medicare, that's the program that provides health care for the elderly and disabled. There's a big constituency for that program, and no one wanted to touch it. It's like the third rail of American politics, so you don't want to go there. So we kept that because the cost of trying to really tinker with it seemed to be too high. We are also going to create some funky new creatures called health insurance exchanges. Think about Costco or Sam's Club as applied to health insurance. It's designed to help you shop, pool your purchasing power with others, and you get a better deal. That's the idea. The states are going to run those and set them up. And then we have employer-based coverage, which still remains for most of us, although we're going to tweak that. So we've got a convoluted little approach here to trying to get to universal coverage. One source of dissatisfaction with the new law is this: it's not universal. After 2014, and most of this stuff isn't happening until 2014, but after 2014, we've still got about 8% of the American public that's left out in terms of coverage. We expect that we will achieve about 92% coverage. That leaves about 25 million people potentially uninsured. So that's not universal. Healthcare under those circumstances, if we think about the common good, it's not a social right. As a social right means I get it. If I meet basic criteria, I'm in. Well, 25 million people aren't in. So it's incomplete. It's better than we have now. We've halved essentially the number of people who are uninsured, but it's still not universal. And many people, particularly folks on the liberal end of the spectrum, were really upset that there was no public option in the bill. The bill, as it passes, is essentially insurance market reform, but it's not a new insurance system like Medicare for everybody. It's not, British-style National Health Service. It's not a Canadian-style single-payer model. It's a unique little hybrid here. And so the end result is kind of a product of committee that seems to please no one. We have an interesting thing. This is a Rube Goldberg-like contraption that's rather fragile. Now, one of the things that happens as a result of the compromise, and I'm not suggesting that the compromise was necessarily an avoidable one, given the way we talked about the bill, but the problem is we have a soft underbelly. And this is what I want you folks to look at in the months to come, the years to come. This bill relies heavily on Medicaid to expand access to care. The principal vehicle by which we're going to get millions of people into the healthcare system as insured Americans is Medicaid. Remember, I told you that's the one for the poor and the disabled. And we're largely doing that by adjusting up the eligibility criteria. We're going to make it easier to get Medicaid. So the income threshold is going to rise. There's a big, big political problem here. And that is, as I mentioned, Medicaid is a state-federal partnership. And what that means for us is if we want to bring in up to 30 million people via the Medicaid program, the states share in the cost of that. And here's the cruel irony of Medicaid in the past 2 years. At the same time, the very same moment we are talking about using this as the vehicle by which to expand access to health insurance, states are literally tripping over themselves to cut their Medicaid programs. And there's a reason. It's a huge chunk of state budgets. State of Florida, state of Massachusetts, it's 1/3 of the budget. And it's growing faster. Massachusetts, as many of you know, many of you may even be from Massachusetts, has a universal health insurance program. It's kind of like the model at the state level for what we did nationally. And the problem is there's real concern about whether the Commonwealth can afford it. And so the question here really becomes most relevant in a recession, which we've been in. And there's a reason. In a recession, more people qualify for Medicaid. There are more people who are poor, who have lost their jobs, who don't have the income earning potential they used to have. So you got more people applying, more people getting coverage through Medicaid. At the very same time, state revenues, free fall. That's a bad set of trends. We are making less and we're spending more. That's a huge problem for states. And the real problem, the real root of it is this. Unlike the federal government, the states have to balance their budgets. Now, the political appeal of using Medicaid was largely that it shielded the federal budget deficit from the true cost of the expansion because, again, it's a shared program. I like to use Connecticut as an example. Any of my friends from Connecticut, you live in a state that per capita income-wise is the highest income state in the US. And so basically Connecticut and the federal government share about half of the cost. So for every person that we bring into the healthcare system under Medicaid in Connecticut, we will ultimately, once the stimulus package runs out, have about half the cost for state, half the cost for the feds. But the problem is that states don't necessarily think they can afford to add lots and lots of people when they have to foot half the bill or a good chunk of the bill. And that's been the issue. In states around the US, we're cutting eligibility, we're cutting optional services, we're cutting all sorts of things, restricting who qualifies, and with state budgets in a tailspin, adding Medicaid enrollees starts to look a lot like a sword of Damocles that's kind of poised over you, fiscal sense. You can't really do it. And there's a second vulnerability of the law. And I'm going to get to those public opinion pieces in just a moment. But one other thing I want you to see before we do so is that we really try to reform the health insurance market. And that's a funky sounding term, but let me help you understand what that means. How many folks here are under the age of 26? I need a show of hands. All right, most of you. Potentially, depending on what your job futures hold for you, you can remain now on your parents' health insurance until the age of 26. It's a good thing, right? That relieves a worry. You now have, someone has to pay for it. There's no free lunch here. If we keep you on your parents' health insurance the next 3, 4, 5 years, then the health insurance company will pay for you under that premium for another 3, 4, or 5 years. We've done other good things. Many insurance companies used to limit coverage to folks who had what we call pre-existing conditions. This is kind of ironic because the reason you want to have health insurance is that you got something wrong with you, and then they say, well, by the way, we'll cover things, but not what's wrong with you. So that doesn't seem to make a whole lot of sense. But we've prohibited that for kids now. We're going to prohibit it for adults later in 2014. But that also raises costs for currently insured folks, for folks who have private health insurance. Another nice thing we did was we said, okay, health insurance companies, you can't limit the amount we spend on somebody's health care to a certain amount of money. For example, Kelsey, I could give you a budget, which is not uncommon, of $1 million. Say your health insurance will pay up to $1 million lifetime. Well, that doesn't seem fair if you get something that requires more than $1 million worth of coverage. So we banned that now. But that means that we've also limited or removed the limitation on insurers' liability. So they now want to raise rates, and that has been one of the biggest beefs that people have with the new law. Rates are going up. This is not a shock. We've expanded benefits. We've limited things that used to be used as a cost containment tool, and we've said you can't do those anymore. And so all of these things are sources of concern. But the big sources of concern are coming, because 2014 is when things really start to hit in terms of requirements. The federal government says in 2014 they can establish, quote, essential benefits for health plans, and that they will also limit the ability of insurers to price based on risk. Well, that means I have to charge low-risk folks the same as high-risk folks, or pretty close to it, and I used to charge them very different amounts. This, again, leads to higher cost. And then there's the biggie, the individual insurance mandate, which is now the basis of lawsuits that are moving through the courts. And I'm not sure if this is going to stand up in court. You read different folks, and different folks have different things to say. Whether it stands up in court or not, the bill has huge implementation challenges. The mandate, which essentially would require you, Genevieve, you have to buy insurance. You have to have proof of insurance, much like any of you who have car insurance in a state that has mandatory car insurance, the same deal for health care. Only this time with a catch, if you don't buy insurance, there's a tax penalty. And the system will be enforced by the IRS. And so if Todd becomes a scofflaw and does not have health insurance, then we will reserve the right to fine you. Well, I say this is an implementation challenge because on a practical level, we love the IRS, that's always good. But even more significantly, the IRS can't file liens or levies on taxpayers. There's no real enforcement mechanism. It's a law, but it doesn't have a lot of teeth. And so Tim Jost, who's a health attorney, has noted that the law ultimately represents an engraved invitation to Henry Thoreau-style civil disobedience, that I am not going to get my health insurance mandate, and what are you going to do about it? Come after me. Okay, levy me. Fine, I'm not paying the tax. Okay, I'll move into Walden Pond. Okay, this is an interesting notion. And the fallout from the bill, I think, has had some significant political implications. President Obama and congressional Democrats took, as the president described it, a shellacking last year in the midterm elections. This is the first big piece of social legislation to be enacted on a party line vote. And the interesting thing about looking at the wake of the vote is that Democrats ran away from this bill in droves. Virtually no one, which is hugely ironic. This is a signal social piece of legislation. This is one of the biggest things since the Great Society, and yet no one's campaigning on it in the fall as like, look at what we did. They're campaigning on it in hushed voices. And the principal beneficiaries of the new law politically seem to have been Republican challengers and Democrats who actually voted against the darn thing, who then used that as props for why they should be reelected. Now, this is where I want to actually look at the public opinion stuff. And so if you've got your green sheet with you, everyone's got a lovely green sheet. These are, yeah, and don't say I never gave you anything. You've got 3 take-home items here that you can put on your walls at home. This is a remarkable thing. The line in the sand, as Father Gabriel mentioned, is that a year ago, when you see that line, the ACA is signed into law, and there's about 43% of the public who thinks we'll be better off, and people were concerned at the time that we had about 35% of the public that thought we'd be worse off. The expectation was that the angst would subside. The expectations were wrong. The angst has increased. And in fact, I think it's remarkable that a year after the passage of reform, more people actually, or almost as many people think we will be worse off as think we'll be better off. It's tight. Statistically speaking, 38% think we'll be better off, but that's down about 5%, whereas we're pretty much stable on the opposition front. And if you look down at the bottom of the page, I think this is remarkable. Then and now. Then, a year ago, about a third of the public thought that the law would be essentially better at helping them get health insurance. Now, 26% do. That's a significant decline. 25% thought that would help the cost of health care for themselves and their families. That's now down to 23%. Not as huge a drop, but it's not encouraging in terms of the trend. 20% now think that we'll be better off in terms of quality, as opposed to 23% before. But look at the other side of the ledger. Most Americans are either indifferent or in opposition. This is not encouraging for the future of this law, because here's the real kicker. The MIG changes that affect most people haven't started yet. The mandate's not being enforced, it's not in play. We haven't begun the Medicaid expansion, which is going to necessitate higher taxes. Now, if we then look at the yellow page that I have for you, and by the way, all of this stuff is available for you to check out. There's a great website sponsored by the Kaiser Family Foundation, and anyone who's interested, it's health reform, easy to remember, .kff.org, and that will take you right to the Kaiser Family Foundation Healthcare Reform website. All the public opinion data is there, projections, talking about what the law means. It's all easily accessible for you. But as you look at this yellow page, I think we also see a huge partisan divide. Democrats like it, Republicans hate it. Independents are somewhat indifferent. But I think the thing that jumps off this page at me is at the bottom. If you look at support among key subgroups by insurance status, the uninsured are actually less favorably disposed to this than are the insured. My gosh, if the uninsured don't like health care reform, who in gosh name is going to like it? This is a remarkable thing. This bill is designed to expand access to the uninsured, and they don't even like it. And I think that's a remarkable thing. And when you look at the past 3 months, in January, more people voted to repeal health care reform, and mind you, it's a Republican Congress now, than actually voted to approve it a year ago. 245 folks voted against it. 219 folks had voted for it a year before. And this is, again, not an encouraging trend. Now, if you look at this, there's a lot going on here. The final piece, which is this buff-colored paper, I think reveals something significant. People don't understand the bill. People don't have a clue. And that's not a shock. It's 2,000 pages long. not what you want to print with your PC Prints account. FYI. Go to the Kaiser Family Foundation Fund website if you'd like to print and learn more about this. Do not rack up, your entire semester's budget and then some and go in hock to try to print this thing. It's huge. Many people who voted for it don't get it. Average Americans still are trying to figure it out. And I think the interesting thing about this buff-colored page is the range of emotion that is evident here. We see at the top people say they don't understand it, but then if you ask, basically feelings, how do you feel about the bill? Interesting responses. Confused. More than half the public's confused. About 27% are enthusiastic, and that's down slightly. About 40% are anxious, and about a third of us are angry. And so this is an interesting set of emotions in response to this bill. And many folks have argued that this is the result of kind of a misinformation campaign. Republicans waged a very, very effective campaign to undermine support for the bill, and they certainly did. They beat this bill up left and right. Other folks have argued that this is kind of a plan to kind of undermine the success of reform. The New Yorker, soon after reform had passed, and as we started to see the public opinion data, the New Yorker denounced the public response, saying that the lies and fantasies about health care reform are the result of a, quote, sort of lunatic paranoia, touched with populism, nativism, racism, and anti-intellectualism that has long been a feature of the fringe, especially during times of economic bewilderment. And now these types of critiques are not new. We've talked about socialized medicine in the 40s and 60s. The problem, though, I think, when you look at the public opinion data, is that opposition is growing. It is not a small fraction of the public. It's a good chunk of the public, and frankly, it's about the same as the percentage of the public that supports the bill. And so I think this represents a huge problem for us. And so I think what we need to do is to wrap up here. I want to focus on my last point, which is we need to come back to community. And we need to change the way we talk about reform, because we've been talking about it as if it's a crisis. But I told you for 85% of the population, it's not really seen as a crisis because they're insured and they can buy health care. And the larger issue, I think, is to draw on one of the folks whose work I like a lot, and that's Deborah Stone, who teaches at Dartmouth College. Deborah argued that we need to articulate a commitment to mutual responsibility for each other's well-being and inspire people to sign on. And when Father Gabriel asked me to talk about the common good, that's it. We need to understand that we have obligations to one another, that it's not okay that people go without care, that it's not okay that this system of ours leaves 50 million people kind of peering in Macy's windows and unable to go in the store. Okay, that's not good. That's not fair. It's not just. But I think the problem is we've tended to put the cart before the horse. We talk about the specifics of plans before we reach agreement on the underlying principles. The consensus we need is about values, about healthcare as a social right. And until we've got that, what we're left with ultimately is the kind of convoluted, cobbled together solution we get in the PPACA. It's a wonderful acronym that we can all use, but it's really a bill that is the result of a lack of consensus about what we should do for healthcare in this country. And I think the remarkable thing we see here is that we need to do a lot of work now to continue to, A, build support for reform, and to try to preserve the strengths of this bill and build on them. The future of healthcare reform, I would suggest, is going to remain in limbo unless we can persuade the American public that whatever system we have is consistent with our values. And I have an idea here. It's actually an old idea, not a new one. For most of the 20th century, when we talked about healthcare reform, when we talked about social reform, we talked about progress. We talked about a system that would reflect social justice, civil rights movement, for example. We talked about healthcare as an investment, as an investment in both improved health and in a more just society. And as we've talked about crisis, we've gotten away from that. Progress during the 20th century was defined broadly. It included social progress, economic progress, technological progress, scientific progress. But there is also an element within this of placing this progress within a larger moral fabric. A just and equitable society was a mark of progress. And I think as an organizing principle, we need to return to that. One of my favorite writers on health and healthcare is a guy named Atul Gawande. He's a surgeon at Brigham and Women's Hospital in Boston. He's written a number of books on medical error, patient safety, and he regularly contributes to the New Yorker. And he wrote a piece in the New Yorker on healthcare reform. And he said in that piece, quote, "In every industrialized nation, the movement to reform healthcare has begun with stories about cruelty. Stories of unnecessary suffering, or even death, become unconscionable in any society that purports to serve the needs of ordinary people, and at some alchemical point, they combine with opportunity and leadership to produce change." I think we need to look for that alchemical point. We need to have a sense of moral outrage that people are left behind, that people suffer needlessly. And that's where we draw upon the notion of the common good. And I think that's not a stretch for Americans. I think if you look back, public opinion data does not support the notion that most Americans think we're spending too much on healthcare. As a matter of fact, only 1 out of 10 Americans, if you look at public opinion data dating back 35 years, only about 1 out of 10 of us thinks we're spending too much. We're happy to spend more as long as we think it's invested wisely. Lyndon Johnson said in 1965 that we live as beneficiaries of this century's great and continuing revolution of medical knowledge. The successes of the century are many. The pace of medical progress is rapid. The potential for the future is unlimited. That's a hopeful vision. We need to capture that and channel it towards social justice. And again, the notion of equality has traction with the American public. I think a narrative, a policy narrative that frames healthcare reform as a matter of simple justice and builds upon a longstanding commitment to equality within the American political culture and public opinion is not a stretch for us. Dan Yankelovich, who's a pollster, said, quote, "The majority of Americans have not become morally obtuse. In private life, most Americans retain a strong sense of right and wrong for themselves and for their families." So I think we need to shift the way we talk about healthcare. We've got to talk about rights, not crises. We've got to focus on justice. We've got to somehow connect the reforms we want to the values we hold. And if we can do that, I think we can believe ultimately in the system we create. And I think right now there is a disconnect here because we need to enable all patients, rich, poor, insured, uninsured, to reflect on their personal experiences with care and to think about the kind of system we ought to have. John Rawls talked about that, asking us to put on, if you will, a veil of ignorance, not knowing where you would be in society, asking yourself what would look like a fair society, what looks like a just society. And I think if we put on the veil of ignorance, we would conclude that we need a system that looks different than what we have today. And so I think political language is vital to the future of healthcare reform. And I think the challenge for us is to harness it so that we move towards a more just, fair, and equitable system. Thank you very much. I'd love to entertain any questions you guys have. I'll hang around, but I'm open. The floor is yours if you'd like questions. We've got a microphone over here. Yes, yeah.
I encounter a lot of people who say that they're not sufficiently informed about the healthcare bill, and I certainly have not read 2,000 pages myself, but I have read many newspaper summary reports, of the major benefits, and it just appears to me as if the people who say that it's uninformed haven't really done much in the way of even reading newspapers. Maybe they're obsolete.
Well, I tend to think when things start to really hit you, either in the pocketbook or in terms of your choice of provider or the way you access care, I think that's when we'll start to see people starting to tune in, if you will. And as you know, newspaper readership is not exactly on a healthy trend line either. But hopefully folks are tuning into other ways to keep themselves informed, because this is a huge change. It really is. Anything else?
Real quickly, two things. For those of you who are still here, there is a reception next door afterwards in case somebody's trying to get something to eat. Two, it seems to me that the crisis language of which you speak, inherently kind of inbred into that language is an element of fear. And it's that fear element that becomes, if you will, a way of shifting the entire process to how does this affect me? Absolutely. Individually. Because we tend to be motivated out of that fear. And the real, I think the crux of the matter, as you said, is how do you change the language of the discussion? And if we do move to some sort of language of progress, or a language of social justice, or even a language of, as we have said, the common good, how do we get rid of the fear that's already there, inherent with this kind of as long as it doesn't affect me kind of thing?
I think that I'd have two quick thoughts in response to that. I think those are really good questions. In terms of getting rid of the fear, I don't think we're going to get rid of the fear. I think the question is more balancing the fear, which will be in existence until some of these provisions take effect. And I think if people see that, in fact, they don't lose their coverage, that the premium does not skyrocket, et cetera, some of those fears will be alleviated. But I think the other piece of this, and this is one of the things I've been most interested in, and something I talk a lot about in my popular culture course, is that we need to tell the story in different ways. You can't just tell the story in Washington. One of the more exciting things I think that's happened over the past decade is folks have started to understand that we can harness the media as an agent of social change. And you see shows like Grey's Anatomy, which is a really popular show, working with writers to develop storylines that introduce key themes and content. Grey's has done a number of episodes that focus on the uninsured, and they use actually one of the figures that was quite popular in the early years of the show was a guy named Joe. He's the bartender. And Joe's a small business person, and it was an interesting selection to have Joe be the guy who's uninsured, because he's a well-liked character. He's kind of a cornerstone of much of the relationship among other folks on the show, and they talk a lot about why Joe's uninsured and why, despite playing by the rules, bad things have happened to Joe, and it's just not fair. And everyone said, well, everyone seems to have a story about Joe. Everyone's connected with him. Can't we do something for him? This isn't right. I think that kind of message, which is educating the public without having them realize they're being educated, it's an almost embedded educational content, is something that has a lot of potential. And actually, the Robert Wood Johnson Foundation has done some studies of this, and there is documented evidence that the public retains information that they see, particularly on medical dramas. That we can actually use them as an educational tool. They've done pre- and post-test surveys of health policy issues covered in Grey's, and public information grew dramatically among folks. And it wasn't a panel survey, it was a cross-sectional survey. So we see a much higher level of public information after something has been discussed on a nationally syndicated show. So I think your point about fear is spot on. I don't think we're going to get rid of fear. I think there will be people who are really concerned about what this means for them. And honestly, there are going to be people, and I think this is part of the disconnect here. Many supporters of reform tried to reassure the public that nothing would change. If you like what you have, nothing's going to change. Well, of course it's going to change. We're going to change things because we have to. We somehow have to either get more money into the system, or we have to limit costs, or we have to do something. So the notion is not that nothing will change and everything you have now you can keep. It's a question of what changes are reasonable, and can we live with the changes, and do we like the changes, and is the net benefit a positive? I think that's the really important point.
My Creighton. I teach in the accountancy department in the business school. Question about shifting, although a very different kind of shifting. When people say to me that they aren't against universal health insurance, but they don't see why they should be paying for the care of the uninsured, what I often try to explain is they are paying for it right now.
Yes.
Because people who are uninsured do get care, and that care is swept into charity pools. It's also shifted over, for every $50 aspirin that an insurance company has to pay for, when a hospital charges them $50 for a $2 aspirin, all of the unreimbursed costs of the uninsured get swept into that aspirin, so to speak, literally as well as figuratively. So that it's a difficult concept, to explain, but the argument that if I lift the $1 million cap on lifetime costs, that the cost to the system must go up, or that if I bring 40 million people who are uninsured into the system, that the cost to the system must go up. That's only, by definition, necessarily true if those 40 million new people weren't costing the system anything to begin with, and yet they are.
I think that's and that, by the way, is the logic behind the individual mandate. We want to get people, healthy people, into the system, paying premiums, because we need to cross-subsidize. We need to have healthy people pay for sick. That's the whole notion of risk pooling is the basis of insurance. And I think your point about the fact that we are paying for this, we absolutely are, and we're paying for it in a thoroughly dysfunctional way, because hospitals are being saddled with the burden of charity care and bad debt, and patients are being saddled with medical bankruptcies, and this doesn't make a whole heck of a lot of sense. And that's why we talked about the individual mandate, but it's that individual mandate that has now become the lightning rod for this entire thing. And I think I looked at a number of different pieces on this. I'm not sure where we're going with respect to the constitutionality of this. I mean, there's no clear precedent for an individual federal mandate to buy insurance. States have done it, but the feds haven't. And so on that basis, many people think that the Supreme Court could ultimately throw it out.
The argument that I've heard that I think is most persuasive, although I agree it's questionable as to whether or not it will be upheld, is that if I go out and own a home and take out a mortgage, then the federal government comes to me and says, if you own a mortgage, you pay less tax. If you don't, you pay more. But the mortgage itself is a privately purchased or acquired vehicle with a private bank. Same thing with health insurance. Fundamentally, it's not as if you go to jail or are truly a scofflaw or a miscreant if you don't buy it. It's just that if you do buy it, you pay less tax. If you don't buy it, you pay more tax. So what was sold initially as a mandate, because there's not much of a penalty above and beyond pay a little more tax, one could argue legally that it's nothing but a tax break being given to people who do buy it, and in a sense a tax penalty offhandedly for people who do not.
I wouldn't disagree with that. I think the only thing I've heard on the opposite side of the equation is that folks would say in response to that, I have a choice of renting or buying, and so I've chosen to buy a house. And so this is different because the federal government is telling you you have to buy the insurance, as opposed to saying, well, you chose to buy the house, so as a result, and I think the analogy might be, you have to buy mortgage insurance, or you have to pay in, whatever type of costs are associated with a federally subsidized loan. I think the thing that's most interesting to me is I have absolutely no sense of how the court's going to deal with this. I honestly think a lot of it's going to depend on the composition of the court at the time it comes before the court. And depending on who's there, and the partisan background of who's there, and the ideological background of who's there, I think we could see two very different kinds of decisions on that.
I agree. Thank you.
Bill?
It's a very interesting argument, Bob. I'm intrigued by your use of this discussion of the crisis rhetoric and how that distorts policy discussion. One of the things that occurred to me as I was listening to you talk about crisis rhetoric in healthcare is I started making a list of the various crises that we're in right now. If you pick up the daily newspaper, you will find just about every day reference to the fiscal crisis, the education crisis, which of course has two parts, the K through 12 crisis and the higher ed crisis, both in crisis, the infrastructure crisis, okay, we know about that in the city of Providence with all our potholes, the Social Security crisis. It seems that in the United States, maybe elsewhere, crisis rhetoric goes hand in hand with advancing policy proposals, that this is the way that we do policy reform. And you're advocating that we not do that, and everything you say about the problems with that, the pathology that comes about, I agree with. But I'm a little curious about how we move to your model. That is, what is it that constrains the American political system from approaching these problems in terms of chronic problems and in terms of rights and justice rhetoric rather than this crisis rhetoric, which I agree with Father Provarnik is very individualistic in its underpinnings. So I guess that's my question. I guess I would ask this really about the healthcare process, political process over the last several years. I mean, how do you account for the fact that there wasn't more talk from President Obama and the Democrats about rights and social justice rather than crisis in the run-up to this legislation?
Yeah, in terms of the political strategy that the president used, I'm not sure I know why the president chose not to emphasize rights, because I think a rights-based theme would have been very consistent with what he campaigned on and what he was trying to accomplish. I think with respect to the larger issue, I think you're right. We do talk about most of these things that you mentioned as crises. I don't think necessarily that we've seen a whole lot of return on that investment. Yeah, because we keep talking about an education crisis, but I don't think the education system's been any better than it was. I don't think that we've addressed the infrastructure problems. We certainly have not addressed the fiscal problems. If we want to look at the federal budget, the state budgets, or anybody else's budget, I think that you're seeing a dysfunctional discourse on this front. In terms of how to get there, I think for me, it's a multi-pronged approach, and I don't think it can be just political. I think that's, for me, there's a powerful draw with popular culture here and trying to get folks to send this message out. I think the analogy I would use is if we look at movies such as An Inconvenient Truth or Waiting for Superman or other documentaries, and we see people starting to talk about issues based on things they have experienced in the media. That's a vehicle by which we can get people to start to open up a new conversation. It's one avenue. It's not going to be enough. I think the larger point, we didn't get here overnight, and we're not going to change the rhetoric of healthcare reform or any of these other social issues that we just mentioned overnight either. I think it's more being aware of the fact that there is a different story we could tell, and we should start to try to tell it. One of the things I think is interesting here is that we don't really have a broad-based social movement for a lot of these things. There's no equivalent of the Townsend movement, back in the 1930s, demanding for old age pensions and social reform on those matters. We don't have folks in the streets protesting. We don't have marches, et cetera, really focusing on this issue. And perhaps we need to do that type of organization as well. But I think the key is you've got to somehow get away from this notion. In terms of the president's decision, I think they were between a rock and a hard place, to be honest. I mean, the Republicans had very little interest in compromise. They viewed this issue in 2009 and 2010 as essentially a political question. And I don't think that the Republican leadership had a whole lot of vested interest in helping the president achieve a signature domestic policy victory. So there wasn't a whole lot of interest in working across the aisle. I mean, there were overtures, but there wasn't a whole lot there. The problem became that we end up with a party line vote. And so the Democrats owned this thing, because not a single Republican votes for it. And so they can then say, look, this is what they did. This is their legislation, and it becomes a referendum. To go back to the common good, I mean, I think, politically speaking, this was expeditious. I mean, it was self-interest, on the part of lots of folks, that they would oppose this bill, that they would not vote for it, that they, if we could break just a couple of folks in that logjam and get them to come in and talk about what's a reasonable compromise, we might have been able to do something. But we end up with a very, very divisive process. I think that's true across the board in American politics today. I mean, we've got a need for community here.
We can continue this conversation, I think, over at the center, and I just want to thank Dr. Hackey and all of you for coming this afternoon.
Absolutely.
Thank you for sharing your wisdom and your thoughts.
Thank you.
I think we were all educated, at least a little bit, I hope. So again, thank you very much.
Thank you. It's a pleasure.